Good afternoon, everyone. Today I'll be talking to you two common most problems one faces post cataract surgery. One is a capsular contracture, other is a capsular distension syndrome. When you plan for cataract surgery, as we know, we want a perfectly centered IOL with no IOL tilt or decentration. You want a perfect optical quality or a pristine optical quality. That's what an optimal result one expects. See, anterior capsular contracture and the shrinkage usually occurs much earlier than the PCO. The capsular contracture basically occurs because of the anterior cuboidal lens epithelial cells metaplasia, which causes fibrosis and the contracture. So, how to diagnose a capsular contracture? One, by examining under direct visualization under slit lamp. Look for any change in the IOL positioning and the result in the shift of the any resultant and refractive shift post cataract surgery. One should suspect a capsular contracture. Why one should worry about the capsular contracture is obscures the vision, affects the IOL position and function. The progressive contracture can sometimes lead to IOL capsular back dislocation. More important in especially in premium IOLs, especially presbyopic correcting IOL, you've done a good surgery with multifocals and trifocals. Due to capsular contracture, one may face a problem. And best form of prevention in these cases is follow up of high-risk cases. I'll tell you what are all the high-risk patients one need to follow up in this. What are the predisposing risk factors one should look into, in especially those who are prone for capsular contracture? Is one is, of course, pseudo exfoliation, uveitic patients, retinal degenerative conditions, high myopia, advanced stage, subtle zonular damage due to previous surgeries. It could be trabeculectomy or vitrectomy, diabetics. So all these patients are prone for capsular contracture. A large capsular rhexis does not eliminate the contraction effect, but the only thing is it assures that in spite of contraction, you will have a clear cut central zone, so you will get away with that. So never leave a patient with a small rhexis, so it obscures the optical quality. So removing the anterior lens epithelial cells sometimes may help in prevention of PCO, but how far it helps in preventing the contracture is doubtful. But difficult in obviously when there is a zonular weakness is there, the polishing of anterior capsule may further damage the zonules and can hamper the surgical results. So one should be very careful with the patients with zonular discence or weakness. So IOL design and materials, it has been shown in studies that capsular contractions are more seen with silicon plate IOLs, silicon optic IOLs when compared to the acrylic optic IOLs. Prolin haptics tends to cause more optic capture than the PMMA ones. Whether the single piece or three piece, the variable results, different study shows different thing. Square edge lens, not much effective, unlike in prevention of the PCO. So one should be very careful when planning, especially when in a presbyopic IOLs or multifocal IOLs. CTRs, definitely in spite of CTRs in high-risk cases, people have found decentration due to contracture and other things. So in high-risk cases, I prefer to, especially in cases with pseudo-exfoliation, the reports have been there. In spite of using CTRs, IOL back dislocation has been reported. So one need to suture CTR sometimes in high-risk cases to prevent the contractures or prevention of dislocations. Especially sutured, you should use a sutured CTR or CT segments in high-risk patients. See, this is a typical case because of the anterior capsular contraction. The AC depth is the markedly thickened anterior capsule. IOL remains in the capsule, but you can see the posterior vault because of the capsular contracture. So, in such scenarios, the simplest solution being doing an anterior YAG capsulotomy. How to do it? You can do a 4 symmetrical incisions you can put at the capsular rim, so that it causes the relaxation. Start at the edge of the capsular axis and extend it towards the periphery. Incision over the IOL haptic should be avoided to prevent the symmetrical asymmetrical lens tilting. So anterior capsulotomy is a simple procedure by which you can get it off. So once you do that, you can clearly see that the hyperopic shift what we had because of the lens vault, it is reduced. So it is one of the simple and effective methods of treatment. Suppose if the fibrosis is too thick and it is involving the obscuring the visual axis also, not amenable for laser also, you have to move on to the surgical maneuvers. You have to do a bimanual techniques. You should not pull it because the pulling may sometimes dislocate the whole, pull the zonular damage and cause a IOL capsular decentration. So closely, gently hold that and make a nix in the center of the capsule. Then using a curved scissors, preferably 23 gauge long lengthy scissors, one can do taking a pupil as a reference mark. You can go all around and increase the size of your capsular axis. So this is the indicated when there is a severe fibrosis which is not amenable to NDAG laser capsulotomy. We can do the surgical maneuver by which you can open the anterior capsule to a larger extent. Of course, one, if he has got an access to femtolaser, you can use a femtolaser also to give a relaxing incision to the anterior capsule so that you can get away with your capsular contracture. Here the laser being applied, femtolaser being applied. This is another method one can adapt. So what are the preparations and actions in a capsular contraction? So one is a vigilant observation, especially in high-risk cases. Select the appropriate IOL. Consideration of CTR and segments usually should be combined with sutures. So meticulous surgery with capsular cleaning should be followed up. Laser, that is AIOC laser or surgery or multimodal combined approaches should be used in patients with capsular contracture syndrome. Now moving on to the second problem one tends to face is a capsular bag distension syndrome. It's a rare complications. You tend to see a presence of a turbid fluid like this between the IOL and the posterior capsule. It could be either intraoperative, early or late postoperative. See, early postoperative invariably it is due to retained viscoelastic, and late is because of the incomplete removal of cortical sense and fibrotic changes. So why we should differentiate between each one is the pathology is quite different. If it is a fibrotic, the management is different. Typically tend to see in the late postoperative inflammatory, it does respond to anti-inflammatory drugs. And if it is a retained OVD or a viscoelastic, we need to just wait and watch, and sometimes the OVD can be washed off. Similarly, there are another classification of capsular bag distension syndrome based upon whether the transparent fluid is there or a turbid fluid is there. What is the status of the PC, whether it is transparent, PCO, or presence of Sommering ring. So some of the differential diagnosis one should know: when you see an opaque turbid fluid in the IOL, it may mimic like a phacoanaphylactic uveitis. Dense PCO sometimes can mimic like this. Propionibacterium acne chronic endophthalmitis sometimes can have a severe plaque and can mimic like a capsular distension syndrome. The pupillary glaucoma, and nowadays with the newer hydrophilic calcified IOLs, we tend to see many such from one of the companies which tends to mimic like a capsular bag distension syndrome. The imaging modalities, definitely yes, anterior segment and UBM both can be used, and even the Schlempfeck imaging. UBM is superior when the capsular bag is very well distended. You can see the much better than the anterior segment OCT. So how to treat this capsular bag distension? If it is asymptomatic, you can observe. If it is an inflammatory pathology, you can add an anti-inflammatory drug. Of course, anterior capsulotomy does help, but the problem with anterior capsulotomy is once you open the PC, this turbid material, once it enters the vitreous cavity, can in some patients may induce a vitritis or a severe inflammation. So you need to closely monitor if you do a blind NDI capsulotomy or opening of the PC. In the surgical maneuvers, definitely you can do a needling maneuvers to open up and through the anterior capsule and drain the fluid. Then there is an anterior chamber aspiration, but if it doesn't respond to any of those things, you can go via pars plana route and open up the PC and aspirate whatever the fluid present between the IOL and the PC. So what are the advantages of pars plana vitrectomy over compared to the NDI capsulotomy? As I told before, one, you can get the fluid for microbiological evaluation, whether to rule out whether it's an inflammation or an infection. The other thing is it avoids the fluid getting into the vitreous cavity, which reduces the chances of inflammation and other things. So this is the pre and post treatment after opening the PC. Similarly, suppose if you feel like PC is very clear, if you don't want to do a NDI capsulotomy, we can make a small peripheral iridotomy and with that open an anterior capsule so the fluid leaks into the anterior chamber and you can just do an AC wash. So if you want to still preserve the PC in some other cases, you can follow this. Of course, NDI posterior capsular opening, it is a routine YAG capsulotomy. Once you do that, you can get rid of this capsular bag distension syndrome. Sometimes what happens is there is an adhesion between the capsular margin and the IOL, which keeps the turbid fluid between the IOL and the capsular bag. Just releasing that adhesion between the capsular excess margin and the IOL will allows the fluid to come into the anterior chamber. You can easily aspirate that fluid. This is one of the maneuvers we can do it, and just tap the IOL, whatever the liquid is there, which will come into the AC, and you can get rid of this capsular distension syndrome problem. Yeah, all the fluid comes out once you tap the IOL. Thank you for your patient hearing. So this is a simple thing. One should know how to tackle it and rule out what are the possible causes for this, and you should treat accordingly. Thank you.
Thank you, Dr. Sunil. I think we are just going it with Dr. Sharath. One question for you, that you're just showing you the draining the fluid out of which is over the IOL. correct? No. So can we wait for some period or immediately you have to take them for surgery?
Yeah, it depends. If it is a homogeneous fluid, not much obscuring the vision, patient is not symptomatic and all, you can wait. But if it is a turbid fluid and obscuring the vision, and if you're not sure whether it is an infective or inflammatory pathology, definitely you can remove it off.
Then how fast you do whenever there is a capsular distension syndrome, you do the YAG capsulotomy?
Yeah, capsulotomy is the last resort. See, the other thing is could be better to go into the AC and try to aspirate it as much as possible. YAG, the only disadvantage I told, suppose if it is an infective pathology, if you are suspecting little bit, if it enters into the PC, it may cause inflammation. That is the only concern. Otherwise, YAG is the simplest of the simple procedures.
Yeah, thank you so much, Dr.